All right, so here we are from the HIMSS event. We're here with Matt Hawkins, CEO of Waystar. Thanks, Matt, for meeting with us. Appreciate it.
I'm grateful to be here.
So, Matt, give us a little background on Waystar. What do you guys do? Where'd you come from? And those kind of things.
Waystar is a cloud-based technology company that is the combination of Navicure and Zirmed, two market-leading revenue cycle management businesses. That was put together in November of 2017, about the time I joined the business. And today, we are a business that has evolved and grown to not only include Navicure and Zirmed, but also two more acquisitions, a business called Hawkins and another business called Ovation. And we now proudly and gratefully serve nearly 450,000 providers that use our technology every day in every care setting. So from a physician office to a physical therapy practice, a skilled nursing facility, to the largest health systems in the country and hospitals as well. Folks use our technology, the Waystar platform, to perform revenue cycle work, to process health payments, and to take care of the needs of their system.
It's interesting. So I'm going to come back to that in a second. So what we're going to do is we're going to march through and we're going to talk about the community, industry, providers, and technology. We're going to talk wide ranging on this, but I want to come back to this. You identify yourself as a technology company, but the two companies you talked about coming together were really revenue cycle services companies. So why, so you're leading with technology. Technology is sort of the backbone for this.
It is. So actually, Navicure and Zirmed were both revenue cycle technology businesses that were well recognized in the industry. They both offered SaaS-based solutions. Zirmed had been invested in a West Coast venture capital firm called Sequoia, and they really did an incredible job investing in Zirmed's technology stack. We took that technology stack, given its modern cloud-based architecture, and at the outset of putting Navicure and Zirmed together, we said, let's take this technology, unify every user on a platform that leverages this technology called the Waystar platform, and we've done that. So now we've united more than 2 billion healthcare administrative transactions, claims, remittances, eligibilities, et cetera, onto this platform. We've also united all of the Zirmed users, and now several, increasingly every week we add more of the Navicure side users to the Waystar platform, and we take a tech-first approach. So the Waystar platform today leverages predictive algorithms to prioritize revenue cycle workflow tasks, to eliminate those tasks because we automate them, and make it easier for end users to use our technology. So that's a stark contrast, Bill, from someone who would just employ a services organization to replace the service work that's going on in their clinic or in their hospital or practice.
Well, it's the difference between using technology and architecture. Really, what you're describing is, if you can put the right architecture together, you can move a lot quicker, you can integrate a lot quicker, and that's one of the bigger pieces, right? So if I were going to do revenue cycle, a lot of services companies would come in and say, look, here's what we're going to do. We're going to do Citrix sessions, we're going to do whatever, we're going to be looking at your screens and your whatever. And I think what you're saying is, hey, we integrate directly and we bring it onto the Waystar platform, and then we put our RPA and our machine learning and our algorithms on top of it on your platform. Is that pretty accurate?
You just said it really well, perfectly.
Okay, great.
And in fact, we work with every health information system vendor. So we work with Epic and Cerner and Meditech. We work with the practice management vendors as well. And we do embed nicely with their technology so that anyone who's using those solutions can interact with our technology as well as theirs. We're not forcing the end user to make a choice. We think that when they step into using our solution, it's a very elegant technology experience and gives them a lift, so to speak. It helps them supplement the work that they're doing within their own systems. And so we like the approach.
It's bi-directional integration.
Absolutely.
We could talk about the technology all day.
Yep.
All right, so couple of things I wanted to talk to you about is we're seeing a lot of, I think the trend I'm going to talk about in HIMSS 2019 is social determinants. right? So
Very hot topic.
we heard it from Karen DeSalvo this morning, heard it yesterday at the Chime conference. The Vivek Murthy, former Surgeon General, talked about loneliness. And he said, the impact of loneliness and isolation is more impactful than obesity on a person's health. And so we're seeing this whole idea of health, and yet 80% of really health outcomes are non-medical. How do you think how are we going to get our arms around all this data that lives outside of we used to say we need all the information at the point of care. But the reality is, if 80% is genetic and other things, how are we going to start creating this entire record for people so that we have all that information? Do you think that seems like a big lift?
It's a monumental lift, but one that will transform healthcare in ways that need to be transformed. I think the phenomenal realization is that with social determinant information, we can add so much context to how to care for patients. It's in ways that are not easily discoverable or not necessarily self-identified by the patient. The simple example I use when I think about social determinants of health is when a patient discloses their physical street address. That's interesting, but when you add a little bit of social determinant context around that street address, for example, they may say, I live on 150 West and Main Street. Well, 150 West and Main Street by itself is nice to know, but when you realize that that's a third floor walk-up that doesn't have an elevator, and we can add that contextual information and present it to the caring provider who's looking after the patient, we can learn a bunch of interesting things about that patient that would help us create better care plans, help us create better engagement with the patient in their own health care, and make for a better experience. And I think that has to come about. When you look at the current practice management solutions and the current EHR, electronic health record solutions, they're mostly provider-centric today.
Right.
I think the breakthrough technologies will become much more patient-centric. And so this patient record will include social determinant information as well as other clinically valuable information that the patient in essence owns. Providers look in at that information and can then care for the patient in new, novel ways. And I think that's the promise of the future, and we're just working to realize that sooner than later.
It's going to be interesting. One of the things I heard from providers when I was a CIO and some of the clients I work with is they have too much information today.
Sure.
So how are we going to, how do we get beyond that? So now you're saying, hey, you should look at their education data, you should look at their housing data, you should look at their family history, you should look at, and they look at some of these things today, but let's just assume we start getting housing data in and you realize, hey, they probably don't have an air conditioner, they're going up 3 flights of stairs and those kind of things. That's a different set of services than traditional providers.
That's a lot of data to process, and to be able to process that information while you're with a patient is near impossible.
Right.
So how do we create algorithms that can basically capture that information and create industry standards that would help dictate, green, yellow, red, easy dashboards or easy monitors for a provider to then, look across maybe a certain set of factors to say, here's how I need to engage with this patient in order to optimize their care based on geography, based on family history, based on diet, based on education levels. And that's what's going to lead us to offer better care to the patients.
It almost might just be simple things like alerts. The health system alerts, the community services that's going to provide another
Great
service
example.
and those kind of things.
Great example.
It's interesting. Well, let's you have a M&A background and those kind of things. So let's talk a little bit about that. So let's talk about the industry. One of the things we're seeing a lot of mergers, and we're seeing some mergers fall through. I haven't confirmed this, but I heard yesterday that the Baylor Scott and White and Memorial Hermann fell through, which wouldn't be a surprise. They're complex deals to put together. I'm actually a displaced CIO from a merger that was successful, and I think is going pretty well. The question I hear all the time is, has this been good? Is this good for healthcare? Is this creating the kind of outcomes we want for, well, let's take it from two perspectives. Is this good for healthcare from a patient perspective is one of the questions. And then the other is, how does scale benefit these large health systems to be able to provide, I don't know, better services for the community?
I think if you look at other industries where M&A work has occurred and consolidation has occurred, in some cases it has been beneficial for patients or consumers in those industries, if you will. Yeah. It's not always clear that it is, and so, and I think you see evidences of that in healthcare. I believe that most M&A work in healthcare today, especially on the provider side, is driven by the belief that consolidation will enable scale and will enable providers to leverage their know-how across a broader network. They'll be able to serve a broader population of patients and deliver them more services or offer them more capabilities or direct them to the best sources within their network that will over time ultimately lead to better care and also kind of a better financial profile. And I do think there are some evidences of that beginning to succeed. But I also at the same time see that that the health system provider side mergers that take place that don't keep the patient front and center in their investment thesis or in the reason why they do these deals, that it's subject to kind of not have the impact that they're hoping to achieve. And I think, you know, if you kind of helicopter back just a little bit and say, well, look at all of the other M&A work that's starting to take place around the providers that are doing their own M&A to serve those providers more effectively. I think that's interesting as well.
Right. But you know, when you have the M&A and you have the big players, sometimes they do not move as fast as they used to, and so then you have new entrants. Right.
Yes.
So there's a couple of interesting entrants, not necessarily a small player, CVS, Aetna. And when you look at that, I think what I'm hearing their play is, and I could be wrong on this, but it's really to disintermediate the patient from the health system in terms of care navigation.
Yes.
So they want to step into that role and help them with everything from handling their bill to where they should direct them to get care. That's interesting. And I guess that speaks to your consumer-centric. So if you were CEO of a health system and you saw the CVS Aetna thing, how would you maybe adjust your strategy to make sure that nobody could come in between you? What are some areas that you would work on?
Yeah, so when you look at what is CVS good at, they are good at understanding the consumer as a retailer and offering services and products around that. What is Aetna good at? Well, they're good at health plan administration. And so if I'm a modern, decision maker in a health system, I would take note in those areas. I would say, and I think, many are, that how do we offer more consumer-like experiences within our health system, and how does that drive or give us conviction to acquire a physician network or an additional hospital or a surgical center or a minute clinic or some type of easy access care site, and not only acquisitions, but how do I invest in more consumer-like experiences in either care settings or in the ways I engage with the patient as a consumer. Patients like web experiences. They like streamlined bills. They like things that are easy to understand and intuitive. And so if I were a decision maker today in healthcare, in a large health system, watching CVS and Aetna, I'd be paying extra attention to those types of capabilities so I could offer them to the consumers I serve.
I saw a presentation 2-3 years ago, and it was CVS, I think it was the CMIO, and he was talking about what they're doing, and they're implementing Epic. And finally, one of the providers stood up at the microphone and said, "My question to you is, what makes you think you can compete with us?" He said, "Parking." That was it. That was his whole answer, and everybody laughed because it was like, Oh, yeah, that's really true because parking's horrible at a hospital.
Yep.
It's great at CVS.
Yeah. It's free in their parking lot in most places. And, you know, in a recent hospital visit, I went to visit a friend who was in the hospital and had to pay $10 to park there for an hour. You know, and so you start to think about things like that are really not healthcare delivery related, but they're experience related. And how do we create experiences for consumers? I think another really important factor is quality. In healthcare, you haven't necessarily seen patients vote with their pocketbooks yet because they're, for the most part, directed to where they should go receive care.
Even with high deductible plans, they're still directed into a network of some
They're
kind.
still directed into a network in some or most cases. And so if I were a healthcare decision maker today in a big health system, I would say, how do we ensure that we have quality measures in place that don't necessarily measure just clinical quality, but experiential quality, to say that I'm creating a trusted, unique experience for the patients in my community, and I'm treating them in a modern and contemporary way.
It's interesting. I'll pass 3 CVS pharmacies before I get to my provider. And so the question becomes, how do they compete with that? And I guess if you're thinking experientially, you say, okay, well, we're not going to put 3 locations between here and his house, but we could do telehealth.
Sure.
And so, you know, you have your first consultation is via telehealth, and now they've actually jumped CVS and gotten closer to the patient.
Yeah. But what are health systems good at? Well, they're good at delivering clinical care. Can we deliver that clinical care via video, a video consultation or a telephone-based consultation? Absolutely. Can we deploy apps that, measure heart, can we deploy or give people devices that measure other vital statistics that could be meaningful in a dialogue with a provider? And health systems could leverage those types of capabilities to stay relevant.
So let's talk. So experience is interesting because yesterday I was talking to a CIO and he mentioned that they have a team working on a single bill. So this gets closer to where you're living right now. Do you find that systems that have spent that time to simplify the billing process, that collections are better, easier, people understand it, fewer phone calls, fewer those kinds of things? I mean, I would think that's absolutely true. I mean,
well, patients increasingly equate their clinical experience with their financial follow-up from the doctor's office or the hospital or health system. So we know that a simple experience wins every day. And at Waystar, our mission is to simplify and unify the healthcare payment process using modern technology for every care setting. And so our belief is that there's a lot of folks that are probably very interested in what you could call the holy grail of healthcare financial responsibility, which is really the payment estimation piece.
right.
If you can get that right, think about all the work that you save downstream, all the hassle and headache that you also save for both those that are following up on the administrative side and ultimately those that are consumers and receiving bills and trying to make sense of them. So this idea of a single bill is powerful. It's even more powerful if you can estimate that bill based on insurance eligibility, based on pre-authorization, informed by patient propensity to pay their bill, and then present that to a patient at the outset of their experience, not 90 days after their service episode. Right. So that's not easy to do. And at Waystar, we're processing about 2 billion healthcare administrative transactions a year. So we've got a lot of rules that govern and automate and streamline that process. And we're helping to make that possible with the clients that we serve so that truly they can present estimation, payment estimation up front. And I think that will be in the days and months and years ahead. If we can drive more of that information forward and create this single bill like you mentioned, that becomes empowering and will unlock a lot of dissatisfaction at the patient level.
So that's a lot better. Well, okay, so the intent of the CMS ONC, price transparency, was what you just described.
Mm-hmm.
I mean, so that people could know, hey, this is what it's going to cost. Now, the practical, I've gone out onto a few of the websites and looked at the, there's no, I mean, one of them had a spreadsheet, and I think it had, I don't know, like 1,800 columns. So I would have to figure out which MRI I got. And I mean, it was very hospital-centric language around it. But that gets closer to the spirit of it, right? Of people want to know what they're going to be charged and how much it's going to cost, what their experience is going to be. So what do you think would be better than just, hey, here's our price list? Would it be some sort of way of calculating, and how are we going to get from where we're at from a policy standpoint? This is what they said to where we need to get, or is it just we're now looking at a consumer-centric focus, and that's going to drive us to different kinds of solutions? They're going to look at a health system and go, I can't understand what this is going to cost me, and they're going to find another one that you just pull up your app and go, oh, you're doing this, it's probably going to be around $2,500.
I think CMS's intent is very good to drive price transparency.
Oh, absolutely.
But to your point, the price lists are long, and there's lots of ways to kind of obfuscate what the real price is, and that's part of the age-old game of payer-provider interactions that impact patients. And so I think it's going to be a combination of several things. First, we've never been able to do more with technology than we can do right now. We can process technology, we can leverage algorithms that create rules that govern data and the use of that data. So really, using eligibility information, using pre-authorization information, in the case where a patient has some form of insurance, we can get pretty close to determining payment estimation for payments now. That's complex. I think that can inform a simple bill that says, this is what insurance will cover for this particular care, this particular treatment, and this is what your responsibility is. And I think that's what's required for us to break through and really create a consumer-like experience that we're all accustomed to in other industry settings here. I don't pretend that it's easy, and I think there's a lot of talk about it, but it will solve a lot of issues if we can get to that point.
Yeah, we're on a 40-year journey of instant transformation.
Yeah, and every derivation of it with capitated plans and everything else to try to simplify things. We've got to crack the code.
So if I were to ask you to sort of, 10 years from now, hopefully I'll be, I won't be retiring, but if I were retiring in 10
hopefully
years.
playing a little more golf.
Yeah, exactly. That's get back to Pebble Beach and do those things. But let's assume I'm retiring in 10 years. How is healthcare going to look different? I mean, how's it going to look? Social determinants, technology, predictive algorithms, genomics. I mean, just dream a little bit about what you think it might look like in 10 years.
I'm going to think big for a second. I think it's totally consumer-like. I think most of my healthcare is consumed by my choice. And by that I mean I have a truly patient-centered health record, not a health record that is about me that exists on a provider domain.
Right.
I want it to exist on my phone, my device, my own technology, and I want to take it in a very consumer-like way to a provider, whether that's in a retail clinic or it's in a primary care physician or it's for some complex case that I'll present that to any caregiver so that they can quickly learn about me. Within my own patient record that's portable, truly portable, the design of HIPAA, right? Mm-hmm. That's my record. It doesn't exist on the provider's domain. I just want to underscore that one more time. I have all my family history. I have that's important to know when someone's caring for me, whether it's a flu shot or it's something far more complex. And then I understand what the payment requirements are in every single interaction, and it's simple. And I can see a single form of payment that I can make for any type of healthcare service I want to receive. And I understand what insurance will cover clearly from the outset. I understand what my copay or financial responsibility will be, if copays still exist. And I'll have information that is pushed to me. Perhaps it's on a phone, perhaps it's on another device, perhaps it's on a watch, that will remind me or alert me to how I can day to day take better control of my own health. Walk more steps. Don't eat the Lucky Charms. Eat the Wheaties or the Cheerios. Whatever.
Yeah, absolutely. Well, that's a good vision. I'll look forward to retiring in 10 years. We'll play some golf at Pebble. That would be great.
Yeah.
Matt, thank you for your time. Really appreciate it.